Hi there everybody, my name is Ollie. I'm a junior doctor living and working in England. And actually, before we go any further, I am giving away a copy of So You Want to Be a Doctor, 3rd edition, on my Instagram page, the link to which is in the description below. So if you're applying to medical school this year and you want some helpful hints and tips as well as profiles of every medical school, this is actually my contributing author's copy. I helped write like 2 pages of this book. And I'm giving it away to one lucky viewer, so go ahead and see the Instagram post on how to win a copy. So welcome back to my YouTube channel. This is going to be the second in likely 3 Q&A videos, sort of ask a brand new junior doctor. Before we jump into this series of questions, please be sure to hit that like button for me, leave a comment and subscribe to the channel, and make sure that you hit the little notification bell and make sure you don't miss any videos as they come uploaded. The first question is simply, how much do you earn as a junior doctor, as in what's your salary like? And it's a question that lots of doctors have already explored on YouTube in very, very great detail. The basic answer, just to keep it really, really nice and simple, is that a brand new FY1, that is a junior doctor like me, a foundation year 1, earns 28,500, is your kind of basic first year out of uni pay. So when you start your foundation training, that's your first paid post after 5 or 6 years usually of medical school. The first year F1, you'll get paid around £28,500. Then in F2, that goes up by another £5,000 to about 33,500. Without getting into the fine details too much, there are a few other things to say, which is that at virtually any point during your medical training, you can do what are called locum shifts, where you basically fill in where trusts have not been able to fill that particular shift with a doctor of the required grade. So they might need an FY1, they might need a senior house officer, an F2, they might need a registrar, they might even need a consultant. And these unfilled shifts, these locum shifts, can be paid at absolutely exorbitant rates. Just to put it into some kind of perspective, I'm working this weekend in the surgical departments doing a long on-call, where I will be paid the basic FY1 rate of around £13.50 an hour. That's what it works out as. But for a locum shift doing basically exactly the same job for the same period of time, is paid at £35 an hour for someone doing the exact same job as me, just doing it as a locum. And that's obviously nearly 3 times the wage for literally the same work. So it just shows you the huge disparity that becomes available for locum wages, and why not having trained enough doctors is actually a real disaster for the finances of the NHS, because we end up spending so much money on locums. Teddy Top says, could you talk about the ACCS pathway? Now, that's a very specific question, but an interesting question. ACCS, or the Acute Care Common STEM pathway, is basically an alternative to post-foundation training that sets you up to go into training in a few related specialties. So for most people, we'll go through medical school, we'll do 2 years of foundation training, F1 and F2, and then most people will either go into GP training straight away, which is 3 years, or core medical training, or as it's now called, internal medical training, which is 3 years, or core surgical training, which I think is still 2 to 3 years, depending on what specialty you want to pursue. ACCS exists as an alternative to these pathways, the Acute Care Common STEM pathway, and I've actually got the specific list in front of me here. So the way it works is the first 2 years of your training are spent rotating through emergency medicine, acute internal medicine, anaesthetics, and intensive care medicine. Those are the 4 key specialties, if you like, and usually you will belong to one of those as a parent specialty, which you will then spend the 3rd year of your training making sure that you're going to get into the training pathway, either to become an internal medicine doctor, an emergency medicine doctor, an ED specialist, an anaesthetist, and so on. But the idea is that there's so much overlap between these specialties that actually you can train juniors with skills in all of these departments, so that when they become specialists later on, they are really well equipped to deal with acutely unwell patients. And the other thing is that ACCS does not restrict you by any means to those 4 specialties. You can also go into things like cardiology, respiratory medicine, pediatrics, many other internal medicine specialties. It won't help you if you want to be a surgeon, but because it's such a good generalist pathway, it sets you up with the basics really well. Charlie wants to know, are staff understanding of the fact that you are newly qualified with their expectations? Yeah, I would say so, especially the nurses, given that they are the ones who will see the new baby doctors rotating in every year. One of the most important bits of advice that I've been given before starting as a doctor and continue to receive is keep the nurses on your side. Be very kind and respectful to not just nurses, but all the ward staff and allied health professionals that you work with. But because nurses are probably the professional group which we as junior doctors interact with the most, simply by volume, they are, yes, very understanding of the fact that we're newly qualified. We don't always get it right. Sometimes we might come across as rude accidentally or dismissive, which I certainly really try not to do, although I know that I did on one occasion, even only a couple of weeks in, because I worded something badly and went to find the nurse and apologised, saying, I'm really sorry, it came across as rude, that's not what I meant, but that's not on, it won't happen again. And I think taking them seriously is also really, really important, because they know the patients a lot better than we do. You don't spend that much time with patients as a doctor, the nurses spend all their time with patients, so all I'm saying is, if a nurse tells you that they are worried about a patient, you should be worried about that patient and go and see them. It may be nothing, because nobody gets it right 100% of the time, but take their knowledge and experience and intuition seriously and deal with it as such. Dizzy Lazy Eve says, do I need to publish to get a seat in somewhere such as Cambridge or Oxford? Assuming that this means a place as a junior doctor in Cambridge or Oxford, not as a medical student, I'm not exactly sure what you mean there, but assuming you mean as a junior doctor, no, is the short answer, because medical recruitment, at least at the junior doctor stage, and to be honest at most stages of our careers as well, is done through a national recruitment process. And certainly when you apply for your first job as an F1, like me as a junior doctor, the two big things that determine essentially whether you're going to get a job in the place or the hospital where you want are your academic ranking at medical school, accounts for a small but still meaningful percentage, that is how well you perform relative to the other people in your year at medical school, so whether you're towards the top of the class or towards the bottom has some impact. And then the biggest thing that makes the most amount of difference is something called the SJT, or the Situational Judgment Test, which is essentially an ethics and decision-making exam, which is not as sensible as it sounds, and it acts as a bit of a random number generator. It's really difficult to predict how well you will do on it, and most of it doesn't really make any sense. I'm not really convinced by the evidence base for it, but we all have to take it. And for 95% of people that become junior doctors, it's only really those things. And in fact, as of 2023, historically points were awarded for selection purposes for having additional degrees and having published a couple of papers, up to 2. But as of next year, or 2023 cycle I should say, all of those points are gone. It seems to be, as far as we know, purely about your score on this situational judgment exam and your academic ranking. So for 95% of people, no, it will actually make no difference. The only difference would be if you want an academic foundation programme job like I have here in the Northeast. If you want one of those in Oxford or Cambridge, then yes, I would suspect that you would have to have published at least a little bit. Indy wants to know, how has your experience so far compared to others in your year? It seems like you've been given a great transition with shadowing, and I want to know if it applies to all trusts. I think you've kind of predicted the answer to that. Some of us have had great experiences. Some of my colleagues have unfortunately had pretty terrible experiences. All I think that means in practicality is that when you're thinking about the jobs that you want to go to, probably doing a bit of research on the hospitals and what the training experience is like for new doctors is probably worth doing. For example, one of the things that attracted me to Newcastle to come back is the fact that it is known nationally for how good its training culture is and how satisfied the junior doctors are that work here. It's got very, very high junior employee satisfaction rates. For some people that might not make a huge difference to where they want to work. They might want to work in a more prestigious hospital that has a name attached to it and maybe an academic unit, but that will work its juniors into the ground because they've got the name and they know that people will come there, so they don't have to treat you as well. Certainly I have felt very supported through my induction into the trust, and my shadowing and my team is fantastic. It's hard work. It is extremely tiring, and I'm still falling asleep at the end of the day. And I think making contact perhaps with doctors in the trusts where you want to go and work, and like I say, doing your homework before you apply, is probably a good idea. And I guess the other thing to remember is that each job in foundation training is only 4 months, and I know that is a long time if you're not enjoying what you're doing, but compared to the rest of your medical career, that's nothing. And at least you will always have an end date in sight. 4 months isn't that long. How much stick do you get from the higher ups? You know, touch wood, actually so far on this job, none. That, I think, is because the specialty I'm in is actually a very niche subspecialty. I'm working on HPB, hepatopancreaticobiliary surgery. The fact that most medical students have never had a rotation in this specialty because it's so niche, well, between HPB and transplant, which are the two things that I do, it would be very rare that a medical student would have had a placement in either of those specialties, which means that all of the decision making virtually is senior led, and we have more registrars available to make those senior decisions. Means that really, if I don't know something, it's simply usually because you would never expect a medical student to know those things, or indeed a very junior doctor. I've learned a lot more about the complex management of pancreatitis and transplant patients and things in the last 4 weeks than I think I learned through all of medical school. So maybe it's just that I've got a good team and supportive seniors, but genuinely, hand on heart, so far everyone's been very understanding about the things I don't know and very willing to teach, in fact. How much autonomy do you experience straight from the off, asks Kirstolio. For me, that has depended entirely on the shifts I'm working. As I just said in the previous question, because the patients I'm looking after at the moment are so high dependency and so sick, the decision making is mostly senior. So other than very basic things like fluid prescribing and antibiotics and things, and even then not that much independently of that sort of thing, because everyone is in a very kind of narrow therapeutic risk of complication curve type situation. Most of the decisions are senior led, either by the consultants or the registrars, all of whom are extremely clever. They've all got PhDs. They're crazy good at what they do. We can really mess up their performance statistics and kill their patients really quickly if we push these patients too far, so we're not given that much autonomy in the day-to-day, and that's a good thing. I think that is genuinely a really good thing. However, last week when I was doing on-call shifts, and you're just basically called to go and deal with problems as they come up, that was actually a lot more like playing doctor, as it were, because you're seeing patients outside of your normal team. We're covering all of surgery, not just HPB, my own unit, but vascular surgery, colorectal surgery. You're thinking about a much wider range of conditions, and even though it's small things, like you might need to correct someone's potassium that's maybe too low, or start them on antibiotics, or investigate the source of their chest pain or whatever, these things are simple enough that you don't need to escalate to a senior who is probably very busy. A lot of it you can simply do the groundwork of by yourself, order the relevant investigations, do the bloods, prescribe first-line antibiotics, fix the potassium, do all these things, and then get a senior involved. I've found a lot easier. So just as an example, if I come across a patient who, for example, they're hypokalemic, what I would usually do is ask them how they're feeling, just check that they're still well, ask one of the nurses to do an ECG, and start replacing the potassium, prescribe all of that stuff, make sure that the nurses are giving it, and then once you've kind of got a more complete picture, ring the registrar or one of the senior doctors managing those patients, say, "Hi, my name's Ollie, I'm one of the junior doctors. I was called to review one of your patients. They had a potassium of 2.5 or something. I've done an ECG and it's normal. I've started potassium replacement, and I've put out bloods for them tomorrow and let the F1s know that those bloods are coming tomorrow so we can check the potassium. Would you like me to do anything else?" And I actually really enjoyed that. Even though it's basic stuff, you can do the groundwork, take some initiative and just get stuff done and try and be useful rather than bothering people about tiny decisions. The wonderful Claire Carmichael, nursing extraordinaire, wants to know, what's the hardest part of your transition? I think for me it has genuinely been figuring out like how the NHS actually works. I did have my assistantship, as I've said before, where you shadow an FY1, but because every trust uses different systems, for example, where I trained as a medical student, we did everything with pen and paper. So all of the ward notes were on paper in folders on the ward. All of the prescribing was done on a paper drug cardex. So where you learn to prescribe properly and do everything in the required format for that. The new trust where I've started working, everything is electronic. So all patient notes are electronic and done on computers. All prescribing is done on an electronic system. So all of that learning that I've done before is more or less useless because none of it applies. All the formatting is different. And simply figuring out how to formally do all of the things that I need to do as a doctor. If I need to order blood tests, it's not as simple as drawing the blood, putting it in bottles and sending it to the lab. It is, have you formally requested these blood tests to be done in the correct way on the system and then submitted them properly to make sure that the lab knows which set of results belongs to which investigation. The really funny example of this is I needed to do a venous blood gas to check someone's lactate, and I didn't want to do an arterial blood gas and ABG because it's painful if I can get away with a venous blood gas because it's a lot less painful to take, and I was doing other bloods anyway. To order an ABG, an arterial blood gas, you go and get your ABG bottle, you request ABG on the system, you just search for arterial blood gas, it shows up and you can order it and print the label and do everything you need to do automatically. I then search for venous blood gas, nothing shows up. I searched VBG, nothing shows up. Just try blood gas, just arterial blood gas shows up. So I was very confused and I went to ask one of the senior doctors and they said, yes, there's actually no way to do this. What you have to do is go and take your blood gas using the same equipment that you would use for an arterial blood gas, take it from a vein, and you need to order an arterial blood gas, but in the oxygen supply component of the order form, you need to write taken from vein, venous blood gas. And it's just things like that that are completely unintuitive. Doesn't to me make any sense why that system would be set up that way. But until you get to grips with all of these obscure, weird ways in which things are done, that has been the hardest part, because everything is like that. Nothing is sensible, nothing is intuitive. There are always like 3 extra weird steps to do even very simple things. So that's what I'm getting to grips with. So that's where I'm going to wrap this episode, guys. I am going to do the 3rd part of this video and release it another time, but thank you so much for watching. Please be sure to hit that like button for me, leave a comment, subscribe, and go and check out ollieburton.com, where you can find my blog and other videos just like this one to help capture the life of a junior doctor and help you into med school. Take care, and I'll see you next time.